Hello, everyone. So this is a very important station which is discussing heart problem with pregnancy. So this is a simulated patient task assessing information gathering, communication with colleagues, communication with patients, patient safety, and applied clinical knowledge. You are gonna see Ellie Thompson, a 36-year-old who has come to your clinic. She is 6 weeks pregnant and she has been diagnosed with pulmonary hypertension. She's currently on bosentan, Nephedipine, and Warfarin. Her recent echo report showed ejection fraction of 35%. So you have 10 minutes in which you should take relevant history and formulate a management plan. So let's talk first, what is primary pulmonary hypertension? So that's when the heart is facing a resistance to pump the blood against the pulmonary artery. It's just because narrowing of the pulmonary artery or vasoconstriction of the pulmonary artery itself. And the pulmonary artery is the great artery, which is draining the blood or taking the blood from the right side of the heart to the lungs. So when there is a pulmonary hypertension, then there is not enough lung perfusion. So the patient will have symptoms of like shortness of breath and tight chest and also recurrent chest infection. And she will be at high risk of blood clots all the time, especially pulmonary embolism, okay? So they treat them with some vasodilators. That's one of them, which is bosentan. Bosentan is one of the medication which is specifically causing vasodilatation of pulmonary artery, and it's a group of medication called endothelin receptor antagonist, okay? The endothelin is a very strong vasoconstrictor, which is acting on the pulmonary artery, and that's an endogenous substance. So the bosentan will compete with this substance and prevent the vasoconstriction. But the problem here is this medication is teratogenic and contraindicated to be used in pregnancy at all, okay? So Nephedipine is one of the treatment also for pulmonary hypertension because it's a calcium channel blocker, so it can cause also relaxation of the muscular layer of the artery, so it can cause vasodilatation. So if you see Nephedipine, she's not taking it for normal hypertension, she's taking it for pulmonary hypertension as a part of her treatment. And definitely Warfarin because she's at high risk of developing pulmonary embolism, so she has to be on blood thinner, okay? So usually this is the regimen for anyone with pulmonary hypertension. Here is the problem of her echo report. The ejection fraction is 35%. What is the meaning of ejection fraction? The ejection fraction is the amount of blood which leaves your heart with each pump. So can you imagine if your heart contain for example 1 liter of blood, and then after the pumping of the heart, only 35% of this amount is leaving the heart, going to the systemic circulation and pulmonary circulation. So that's very, very minimal amount, and it reflects that your heart is gonna fail to do the job. So what is the limit above which we can allow pregnancy? Is 40% and above. So anything below 40%, we can't allow pregnancy. But this patient came pregnant, so we need to deal with the situation and explain all the risks, okay? So the normal ejection fraction should be from 50 to 70%. So your heart doesn't have to pump all the blood, but from 50 to 70%, that means your heart is doing efficient job. But below 40%, that means the heart is gonna fail or is not doing the job as properly going to be. Okay, so how we can approach this station? First of all, we need to take a full history, and because this is a cardiac case, we need to ask about specifically about the symptoms of right-sided heart failure and left-sided heart failure. What are the symptoms of right-sided heart failure? We just told about breathlessness and also chest tightness, recurrent chest infection, chest pain, okay, cough, sometimes coughing of blood, okay. So what are the symptoms of left-sided heart failure? Lower limb edema, also easy fatigability. Because she's cardiac case, she may be aware of her heartbeat. She can't do too much effort, like easy fatigue. She can't go upstairs like as normal. She has to rest in between. So you can ask her, like, you know, how much from the daily activity you can do, how many flights of stairs can you go, like that, okay? And also like, you know, headache, easy fatigue, tiredness, these kind of stuff shows that the heart is not working well. And the most common thing you need to ask or to exclude is swelling of the lower limbs, because that's a sign of heart failure, okay? So after excluding or asking about all the symptoms, we need to ask how long she is suffering from this condition, okay? Because some ladies may have this condition for a long time, and then their life is like, you know, just coping with this. But some ladies may have developed this condition recently, and they don't know, like, you know, how far they can cope during pregnancy and this kind of stuff, okay? We need to ask, is it a planned pregnancy? Definitely should be unplanned, because usually if we diagnose a case like that, we will offer them a very strong long life contraception. Or if she declined that, usually because the lady may be younger, she will decline long life contraception. So we put them on like progesterone only pills. Or however, you know, even the hormonal contraception may be contraindicated because of their VTE risks and these things. So we advise them for sterilization or tubal blockage, but not all women accept this. But yeah, that pregnancy is planned or unplanned. And how do you think about it? Are you happy to continue, or like, you know, are you are not happy? Okay. And we need to ask about the normal items in the history, but we have to stress on the obstetric history, because if this patient had a previous pregnancy, we need to ask whether this condition was there during her pregnancy, how was the mode of delivery, and how did she cope with the pregnancy, and what about the postpartum period. That's because, you know, the most serious period is the postnatal period. It's just because, you know, the placental perfusion is going to return back to the circulation suddenly after the placenta delivered, and that will add 500 cc of blood to the circulation, to the blood, to the heart. So that will like, you know, predispose to like heart failure and up to death, okay? So we need to know how was her last postnatal period, and whether she was on any contraception or anything like, you know, before this pregnancy. Also want to ask about her medical history, if she has any like, you know, associated medical problem like high blood pressure, any other cardiac condition. Like some ladies may develop this pulmonary hypertension is just because of chronic heart disease or any other heart condition, okay? We need to ask also if she has any previous history of blood clots, also any previous surgeries, specifically heart surgeries, and what about her smoking habit and alcohol and these kind of normal history questions, okay? In the examination, we need to see her BMI. We need to look for any presence of lower limb edema, and also we need to check her observations in terms of pulse, temperature, blood pressure, and respiratory rate, and don't forget the oxygen saturation as well, okay? And then here we will start to explain like what is the risk of having such a condition with pregnancy. So we will tell her that usually during pregnancy, the heart needs to do extra effort to pump more blood to be sufficient for you and your baby, because the womb needs a proper circulation and blood flow going straight away to the placental circulation in a very high rate, and that puts a lot of effort on your heart, okay? And that's physiologically changes even if your heart is healthy, and it's working more harder during pregnancy, okay? So now your echo report is showing that your heart is not doing the job properly, because the amount of blood leaving your heart with each pump is only 35%, and that's a minimal amount if we speak about it. So that means if you continue this pregnancy, that will put more and more effort on your heart, which is already weak from before pregnancy. So in situation like yours, it becomes very challenging to the medical team, because the safest option here is to advise you to go for therapeutic abortion. However, some ladies may agree to continue pregnancy, but they have to know all the potential complications that may arise during pregnancy. So how do you feel about it? Like, you need to ask her, like, we can't tell her go straight away and terminate your pregnancy, but we need to tell her that this pregnancy is threatening her life. And if she accepts that risk and she wants to continue the pregnancy, then this is her choice, okay? So, but we give her the safest advice. The safest advice is to go and do termination. However, some ladies may think that they want to continue the pregnancy in spite of all possible risks. And if this case came to the exam, the lady will ask you, what are the risks? And I want to continue pregnancy. So what will happen if I continue the pregnancy? So if you continue this pregnancy, we need to do an urgent referral to the cardiologist, okay? And especially a person who is specified in treating cases of pulmonary hypertension, and that will be in a pulmonary hypertension specialist center, okay? We need also to do an anesthetic referral. So you need to be seen by the anesthetist from early of pregnancy. Why now? Usually when we refer some pregnant lady to the anesthetist, that will be done around 32 weeks. However, this patient is very high risk from the beginning, because at any point, if we think that this pregnancy is threatening her life and she chooses to terminate at any point, then she has to be exposed to anesthesia. And general anesthesia here is very risky. So the safest anesthesia route is the spinal, but we need like a review from the anesthetist as soon as possible, okay? So we will do urgent referral to the cardiologist and the anesthetist from the beginning of her pregnancy. You need to know that this pregnancy is very high risk, and then your care will be in a consultant-led unit, and it will be under care of multidisciplinary team. This will be consisted of senior obstetrician, senior cardiologist, critical care specialist, and a neonatologist. You will need more frequent visits and more frequent scans. The scans you need will include the dating scan at 12 weeks. You need anatomy scan or anomaly scan at 20 weeks. You need fetal echo because, you know, if anyone with a cardiac condition, there is a possible risk that your baby also will have a congenital heart problem. So you will need a fetal echo around between 18 to 20 weeks. And also you will need serial growth scans from 28 weeks ongoing. That's because the risk of small for gestational age, okay? Here, your medication needed to be changed, okay? So let's speak about Bosentan that should be stopped straight away. You can't continue that medication because it is teratogenic and it carries the risk of predisposing to congenital anomalies in your baby. So that can be replaced by another form of medication, like, you know, we call it prostacyclin, which is more safer during pregnancy, but this will be advised by your heart doctor. Regarding Nephedipine, it's completely safe during pregnancy. You can continue to take it. And in regards of Warfarin, the Warfarin can have some adverse effect, especially during the first trimester, unless you have a prosthetic valve replacement before. So if you don't have a prosthetic valve replacement, then we need to change your Warfarin to another safer medication called low molecular weight heparin. These will be some injections given to you like like a kind of higher dose than a prophylactic one. We call it a treatment or therapeutic dose. And that's to prevent you from having any blood clot, okay? So the risk of warfarin can be bleeding in the baby, or also something called warfarin embryopathy, and like risk of congenital anomaly. So please be careful if the patient is taking any medication. You will not pass the patient safety module in the station unless you see at least one of the side effects of the medication to the patient, okay? So for each medication you are gonna stop, you have to tell why you are stopping this medication, at least one side effect from the medication, so that you can pass the patient safety module, okay? Or domain, I mean. So that's hair medication. So then you, because we need here to discuss what is the effect of pregnancy on pulmonary hypertension, and what is the effect of pulmonary hypertension on pregnancy. So I will start with the effects of pulmonary hypertension on pregnancy. That can be miscarriage, it can be cardiac anomaly for your baby, that can be risk of bleeding because you will be on blood thinner, and risk of growth restriction is because your heart is not pumping enough blood. So the blood reaching the placenta will be not enough. So the risk of risk of a small baby is there, and risk of intrauterine death, okay? The most important risk here is preterm delivery, because usually in case of pulmonary hypertension, we tend to deliver you early. We will not go beyond 36 weeks by any chance, because that will be a life-threatening period. So risk of preterm delivery is there, okay? What are the effects of pregnancy on your condition? So there is a risk of developing high blood pressure during pregnancy. We call it pregnancy-induced hypertension or preeclampsia, and that's why you need to start on aspirin from 12 weeks till your delivery. the risk of blood clots, and that's why you need to go into a blood thinner throughout your pregnancy and for 6 weeks postnatally, and then you can be changed back to your warfarin. And then the risk of right-sided heart failure, when sometimes your heart is failing to do the job and can't cope with the demand of the circulation, so there is a risk of heart failure. And also the risk when we change or stop one of your medications that can cause deterioration of your condition up to life-threatening situation. So there is a small risk of death, but the major period which carry the highest risk of death is the postnatal period, and that can be up to 50% of cases, unfortunately. And that's why there is a risk of being hospitalized in the hospital throughout your pregnancy, or sometimes from the second trimester till your delivery. So coming to plan your delivery, usually the safest option for you is to go for elective cesarean section. Vaginal delivery here is very risky because when you do the pushing and Valsalva maneuver to deliver your baby, that will limit, your chest capacity, and also your heart needs to pump more bloods, and it will be very, very difficult. So the safest option is to have a C-section, is the recommended route of delivery here, and it should be planned between 32 to 36 weeks. If you still have the chance to choose a vaginal delivery, however, it will be more risky than if you have a C-section, but it's absolutely your choice. But if you have this option, your delivery should be in a tertiary unit where everything is available for you and for your baby. Okay, and you shouldn't go into a spontaneous labor. We should plan your delivery by induction of labor so that the cardiologist and the senior obstetrician and the CCU people, critical care people, all are around and know the time of your delivery, and they will be well prepared to deal with any emergency if it happens. Okay. If you have a vaginal delivery, you will need continuous CTG monitoring during your delivery, and you will be advised to take epidural because that will also relieve the pain, and that because when you are in pain, that will put effort on your heart as well. So we will block your pain receptors, and also we will go for shortening of second stage of labor when you have instrumental deliveries for delivering your baby, so you will avoid pushing. And there is a specific medication because you will be at risk of bleeding after birth because of your blood thinner, antenatal blood thinner. So there is a risk of PBH or bleeding after birth. So we can use all of the medication apart from ergotamine. This is a medication which is contraindicated in heart problems and high blood pressure. After your delivery, you may need to be admitted to the cardiac care critical care unit. We call it CCU, and because this is the most critical time, and you need to be closely monitored by the heart doctors and the anesthetist and critical team as well. Unfortunately, breastfeeding is not really recommended because all of the medication which makes dilatation of your pulmonary artery are excreted in the breast milk, and it may harm your baby. So weighing the benefits and risks of either to take the medication or to give the breastfeeding, it's very important to take your medication, and your baby can have bottle feeding. Okay. So I'll give you some time. You don't need to decide anything right now. I'll give you some time to think about it. I'm again telling you that the safest option is to go for termination of pregnancy. However, you still have the choice after knowing all of these risks to continue the pregnancy. And as I told you, there is a risk of something which may be life-threatening to you. And it's a considerably high percentage. Thank you.